meningitis. There are three common types of meningitis. One is viral, one is bacterial, one is tubercular. And you have to diagnose this case by biochemical investigation only. And you will be able to diagnose without seeing the patient, just by looking at the biochemistry report. That's what I will tell, and at the end you will answer. Okay. So many things I will tell today deliberately, only to give a complete overview of CSF, so that you don't require anything more in your MBBS course. Now, since I will be in this campus, so if I am not covering anything in this class, today's class, and if you come across something new, please do inform me. I will try to incorporate that thing in my lecture. So in subsequent classes, I will make it as completely as possible. So don't take any photograph. First of all, switch off the mobile and note down whatever I will be telling you, and note down. Or otherwise you memorize it, or you simply this thing. Read it. I will give everything. No issue. I will give everything later also. I am not going to take anything. Only thing is that I want that you try to remember in the class itself. I read only once today in the evening from physiology book and from anatomy book, and that will make the entire thing clear. The biochemistry, many parts will not be written in your undergraduate book. That is the reason why I am asking you to write down. Okay. So from this side you come to see this thing. I will explain a little bit. From this side, all of you come, have a look, closer look. Chalo. Acha, next class will be on Saturday. Try to come a little early. Try to come a little early so that we can finish it, because on Saturday many of you want to go home also. So I want to release you earlier. So look very carefully here. Look very carefully. Somebody try to hold it. এখানে ধরে তোলো এটার উপর রাখো, এটার উপর রাখো, এটা একটু রাখো, দেখো উঁচু আছে, সাবধানে রেখো। Just look at this structure. This is the actual naked brain. You see the structures are like, these are called gyrus, just like this. Okay. And if you collect one brain from the slaughterhouse, you will see and what consistency, just like slightly something frozen dahi, not more than that. So you have to handle it very carefully. So this is the structure. On this structure is covered by a layer, that is meninges. Brain is covered by meninges. There are three meningeal layers. See, brain is on top of which, brain is housed in the, brain is housed within the cranium. Why it is housed within the cranium? See, you have kept pencil in the pencil box. There is no inside covering. If you move like this, pencil is not going to break. Only the tip might break. In contrast, the jewelries are kept always with some soft coverings, with some cushioning effect to get an cushioning. Why? Because jewelry is having fine intricate structure, and if you go on moving like this, that lacks a pencil box, the jewelry, that intricate part is likely to be broken. And that is the reason why brain is housed inside a strong thing, but with a covering, just like a jewelry box. That's cushioning effect. That is done by, number one, Dura matter. Dura means tough, durable. So Dura matter is something like this. And all of you have dissected the fasciolata. You know the fasciolata structure you have seen. It is similar structure, is just like fasciolata. And if you require to replace surgically the Dura matter, the Dura matter, you take a fasciolata graft and replace it with the Dura matter, because this structure matches. So this is the toughest layer that covers this part, that you can see this part. So it covers like this. So that is Dura matter. The next layer is arachnoid matter. Arachnoid means cobweb like. So it will be like this. So arachnoid matter also remains like this. So this is Dura matter, this is arachnoid matter. So one layer is covering the brain, the other layer is simply getting reflected onto the under surface of the cranium. That is endosteal layer, and there is a basically cephalic layer, basically brain covering the brain. Okay. So this is the space between the dura mater and the cranium is called extradural space. So if there is a hemorrhage here, it is very easy to puncture and get the blood out. So no contact with the brain. If it is between the dura and the arachnoid, that is called subdural space. Now, in contrast, arachnoid pia mater means soft, matter means mother. So pia mater actually remains like this, something like full covering. That varus covering is there. So this is arachnoid matter, this is dura matter. So under the subarachnoid space, this space is called subarachnoid space, and it is the space where the CSF lies. So here CSF is remaining. The CSF is just like a buffer, acting just like a shock absorber. You have seen in the football ground, many people have given heads, moving head. We are moving also head like this. So what is happening here inside? The brain is moving from this side to that side, but because of the fluid level, it is not directly getting hit onto the under this cranial, this bony surface. Because that water is preventing it from being hit. But there is a limit of everything. If it is severe, then obviously the other side is going to be injured. If you break the skull somehow by hitting, a direct injury here, direct injury that side also. So that's the purpose. This is basically a cushioning effect, protecting effect, and it is the CSF which gives circulation, nutrition, maintaining blood flow. I will tell you the 5 functions of CSF. And when there is a disease, you see there is a length, the spinal cord. So it is present in the vertebral column. You see, actually the brain is housed here, and this is called foramen magnum, and this is lumbar vertebra. There is a cervical vertebra. So cervical where there is an opening. This remains like this. You can see this bony part on the back, on your spine also. So basically, spinal cord remains here, and the importance of this spinal canal I will tell you during my class. So this part is there, but whole of this thing, whole of spinal cord doesn't remain in the spinal canal. There is some leftover place that I will discuss also during this class. So this is in brief about this CSF, where it is present. It is present in the subarachnoid space, both in the cranium, that is in the brain, covering both the cerebral hemisphere. If you cut here in the middle, just like that thing, if you cut it here, you will get a structure like this. But if you cut it here, one structure I will show it where the ventricles will be shown. In this brain, there are ventricles also. There are some openings where the cerebrospinal fluid is also there. The cerebrospinal fluid is present both above both the cranial surface over the brain and also the spinal cord, and it is continuous. যাও তোমরা যাও পরটা এসো পরটা আমি বোঝাচ্ছি ওই আছে তোমরা খাইটা শুনে নিয়েছো তো খাইটা শুনেছো তো এবার তাড়াতাড়ি এসে অনেকটা সময় লাগবে আজকে তোরা দুদিন প্রায় ঘন্টা 1.5 ঘন্টার উপরে সময় নেই See, this is the structure of the brain, and this is the structure of the spinal cord. If you cut this part, middle, exactly like this, if you cut it, we will get a structure like this. So, এদিকে এসো তো হোল্ড করে দে তোলো 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 এদিকে তোমরা এদিকে এসো এদিকে চলে এসো এদিকে চলে এসো you see the structure, and that is the reason why I am asking you to collect one brain sample from the slaughterhouse, from the goat, and you will feel what is the structure of the brain. Human brain is just like that. So So it is having a structure like this. These are called gyri. You see, this part is naked. Some covering is here. That covering has been removed here. Only a few things are there, because if you remove it completely, maybe some of this structure will not be maintained. That's why they have kept a little part to preserve the actual anatomical structure of the gyrus. Okay. So how the setting the calculate jhabala korche eta. এই ওকে ডাকো তো একবার রেজিনাকে সেটিং করে একটুখানি এটা সেট করতে বলবে কালকে এই ঝামেলাটা করছিল কোথায় গেল একবার রেজিনাকে ডাকো তো সেট করুক এটা মেনুতে গিয়ে হবে আচ্ছা এখানে দেখে না একবার so brain is housed in this cranium as I was discussing with the pencil box. See, if you put a pencil box, move the box like here, it is not going to be broken. But ornament, any ornament cannot be moved in that position. It is always kept with a cushioning effect, both on the under surface and on top of it also. So brain is like much more precious than any jewelry. এইটা দেখো তো ঠিক হচ্ছে না কিছু এইরকম করছে বারবার দেখো 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 তো ও ও এটা অলরেডি ঠিক আছে দেখো একটু রেডি করে দাও সো ব্রেন ইজ হাউসড হিয়ার in the cranium and it is covered by three layers. These three layers are called meninges. One is dura matter. It is the dura means tough and durable. So dura matter is just like this. And I was discussing the fasciculata you have seen. Similar structure is dura matter. So if you require surgically any dura matter to be আস্তে আস্তে কথা বলো না এটা শুনো একটু তো that fasciculata graft will be most ideal graft for replacing dura matter. So it remains on the brain just like this. Arachnoid means cobweb like. It will be like this. It will be also placed like this. Paya means soft. Matter means mother. So it is a soft matter. It remains like this. Something. So this is paya matter. This is almost with the structure in continuity with that thing. It is very difficult to remove this thing. So there are three layers. One is this one, is arachnoid matter. One is dura matter. One is arachnoid matter. This is dura matter, and one part of this dura matter is reflecting onto the under surface of the cranium, so that part is also covered. So the space between the under surface of the cranium and the dura is called extradural space. And when there is a head injury, if there is any hemorrhage here, so that if you puncture here and clot will be removed, brain is intact. There is no problem. Patient gets immediate consciousness. If he is unconscious, he will get consciousness fully. So that's easy. So under this space is called subdural space. Under this space is called subarachnoid space, and it is the subarachnoid space where cerebrospinal fluid remains. And it is in continuity with the spinal cord also. So it is covering basically the subarachnoid. This CSF is basically present on both the surface of the cerebral hemisphere as well as on the spinal cord also, because spinal cord is also having meninges. So it is coming out. The spinal cord is coming out from this opening in the brain that is called foramen magnum, and these are lumbar vertebrae. So in the vertebra you see there is a canal. And the diameter of the canal also varies, and it is placed like this. This part you can see on the back as the projecting part, bony part. These are spinal processes. These are very much important anatomically and surgical point of view, and from lumbar puncture point of view. I will tell you in the class. So this is in continuity. So that basically that fluid is acting as a buffer. As I was moving that, if the head is moved like this, ideally the brain is also moving like this, but it is not hitting the other side of the cranium, this bony part, because fluid is there. But there is a limit for everything. If you make it very severe, if that it is overpowered, then there will be injury. And similarly, if it suppose it is hit strongly with a rod, it will be broken. So it will, this part of the brain is also injured, the other part of the brain will also be injured, because that structure will be no longer continued or maintained. So basic purpose of CSF is to act as like a shock absorber and to give nutrition, to drain the fluid out. There are 5 main functions of CSF. The brain will basically float in that water. So it will give a buoyancy also. Now sit down. So what I have discussed, so write down where it is present. CSF is present in the subarachnoid space. At least you must be able to tell this thing. Between the arachnoid matter and matter you have learned. The ventricular system I will show. Around and inside the brain and the spinal cord. Where CSF is present, this much information you must have. Now CSF, where it is produced. See, all the body fluids are basically formed from plasma. And all the body fluids are formed as ultrafiltrated, like urine. Urine is formed from glomerulus. It's a tuft of capillaries. Similarly, we are having pericardial fluid, we are having peritoneal fluid, pleural fluid. All these things are produced from the capillary. It is produced from choroid plexus. This choroid plexus is present in both lateral ventricles. In the short while you will see the picture. There are 2 lateral ventricles, a 3rd ventricle and a 4th ventricle as ultrafiltrate. Ultrafiltrate means protein concentration will be remarkably low. In urine is also an ultrafiltrate, and you know that urine total protein excretion in 24 hours in an otherwise healthy individual ranges from 50 milligram to 150 milligram, not more than that. So CSF will also contain protein, but it is in very minute amount. So daily secretion is about 750 ml, but total CSF volume in an adult, in a normal adult, is approximately 125 to 150 ml, because the head size is not same in all individuals. So because of the size, there is not a fixed volume for anybody. So a child will not have the same thing as an adult. Even an adult, you can have diverse head size. So there will be some variation physiological, that is quite normal, natural also, proportional to the size of the brain and the cranial cavity. So some variation is there. So you see that there is a 750 ml daily secretion, but the total volume at any given point of time is 125 ml. So there must be a drainage system, just like urine formation. We are forming urine and we are passing, blood is getting empty. Again we are drinking water, that urine is formed in the blood, and again we are passing. So similarly CSF, there is no urine system like that. So CSF gets reabsorbed. How it is getting reabsorbed, that I will also discuss. So CSF production rate is on an average less than 0.5 ml per minute. You remember 0.3 to 0.4 ml normally. And 50% of the total CSF is replaced in every 5 to 6 hours. That means 100% is replaced by 12 hours. There is a continuous production, just like urine production, and there is continuous also reabsorption. So these figures you have to a little bit remember. And CSF flow, as I was telling, it is over the surface of the brain and then over the surface of the spinal cord, and it is in continuity. There is no break. In a short while you will also see the entire picture. You have to write a little faster. Later you can, later I will give time those who cannot write it. See, this is, this section what you have seen is cut like this. But if you cut a brain in the coronal section just like this, if I put it layer here, if I take a section like this, it will look like this. It is for eye. I will dark it is একবার রেজনাকে দেখে নিয়েছে বলে অ্যানাটমি স্পেসিফিক করে নিয়ে একটু না একটু লাগবে পরে 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 বলবো এই দেখো এই টাকা এদিকে এটা নিচে নামিয়ে দেবো নিচে নামিয়ে দেবো একটু choroid plexus here just like glomerulus. So there are in lateral ventricles, there are, you see the first part where it is produced in the lateral both ventricles, and in the 3rd ventricle also and 4th ventricle there is choroid plexus. So it is produced from this choroid plexus. Now this is schematic diagram, you will see, read it in the anatomy book also, and there is a communication between the lateral ventricle and the 3rd ventricle through foramen of Monro. I will discuss, and from 3rd ventricle to 4th ventricle again basically by another duct, that is cerebral aqueduct duct. This part again also. So this you read a little bit from the anatomy book, it will be very clear. This part you write down completely. How CSF flows, just try to understand. There are two lateral ventricles. In each lateral ventricle there is an interventricular foramen called foramen of Monro. First you try to understand, then you write down. From there coming to third ventricle, from third ventricle to through aqueduct of Sylvius to fourth ventricle, and in fourth ventricle there are three openings. One is central, the median called meningi, and two on lateral side, lasca. From median side the fluid is coming out and covering the spinal cord. On two lateral side, lasca, two lateral openings, fluid is coming on the surface of the cerebral hemisphere. That you must remember. And from the subarachnoid space again, it goes into the arachnoid villi, and from the arachnoid villi through superior sagittal sinus venous system, this CSF is reabsorbed. So now you write down at each function here, because how CSF is circulated, one question might be there. How CSF is reabsorbed? This structure basically you have to write and you have to memorize. Why? Because in brain tumors, these narrow ducts will be obstructed. So there will be some obstruction to the flow of CSF, and that will cause headache and other symptoms. You have seen that small tract through which the fluid is coming. If there is a tumor, that place will be, that area will be blocked basically, or there may not be any production. Lateral ventricle area completely blocked. Both lateral ventricles are fully blocked, suppose with the tumor. So they are unable to produce CSF. So this only you read from the physiology or anatomy book today itself. So from both lateral ventricles through third ventricle coming through foramen of Monro, from third ventricle to fourth ventricle coming through cerebral aqueduct or aqueduct of Sylvius. In the fourth ventricle, remember there are three openings. One is foramen of Meninges, located in the median part, central part. M for medial, Meninges. Lasca, lateral. L for lasca. M for Meninges, L for lasca. From two lasca opening to cerebral hemispheres. Now, you look there at the front part from foramen of Meninges passing through the foramen of Meninges and filling of the spinal subarachnoid space. From the lasca travels into the subarachnoid space of the cisterns, ventricular system and the cerebral hemisphere, overlying the cerebral cortex. You write down, I will show it schematically and also through animation, the subarachnoid space, how it is reabsorbed. Through outpushings in the superior sagittal sinus is a venous system. If you look at the cerebral hemisphere, on the top of which, in the middle part, there is superior sagittal sinus and the falx cerebri, which is dividing the two parts of the brain. And the lower part, it is inferior sagittal sinus, but CSF is reabsorbed from the superior sagittal sinus. And due to the pressure gradient at the arachnoid granulations. Why? Because if there is no valve-like mechanism, then blood will pass through enter into the CSF. So basically, because of the pressure gradient, CSF goes from cerebrospinal fluid, subarachnoid space to the venous side and not the reverse in the other way. Do you understand? Otherwise, there will be mixture of cerebrospinal fluid with the blood, just like glomerulus. If the woman, there is no Bowman's capsule, then if that is destroyed, then the urine will get mixed into the blood, something like that. So it is allowing this arachnoid villi is allowing just like a AV valve-like mechanism. This arachnoid villi finally grows into the arachnoid granulations, and it's a one-way traffic. And from the arachnoid granulation, CSF is reabsorbed. This I will show it to you in a diagram and animation also. Most importantly, from a clinical point of view, is this one. Again, I will elaborate on this one. Write down In the subarachnoid space, CSF comes in contact with the perivascular space around blood vessels and leaking occurs here during inflammation. Itis, meningitis, or any itis. Itis means inflammation. So meningitis means inflammation of the meninges. So where due to inflammation there is leaking. The CSF abnormality is due to leak here from at this place, not from the whole area of the meninges. Whole meninges is definitely inflamed, but the abnormality of CSF you will get is because of leak in the subarachnoid space where it is coming into the contact with the blood vessels, and that we will call abnormality in the blood, CSF abnormality. Is this part clear? তাতে লিখে আমি ছবিটা দেখাচ্ছি। এই দেখো সুপিরিয়র, এটা venous structure দেখো, this is the actually subarachnoid space and this is outpouching called arachnoid granulation, and this is superior sagittal sinus. জাস্ট একটা অ্যানিমেশন দেখালেই ব্যাপারটা ক্লিয়ার হয়ে যাবে। এই দেখো ল্যাটারাল ভেন্ট্রিকল প্রডিউসড হচ্ছে সিএসএফটা, ওই দেখো সাইনাসে চলে গেল, থার্ড ভেন্ট্রিকল, ফোর্থ ভেন্ট্রিকল, এখান থেকে নেমে এই দেখো স্পাইনাল সাবারাইনাল স্পেসে চলে এলো, ওই দেখো আস্তে আস্তে কভার করছে সেরিব্রাল হেমিস্ফিয়ারটাকে, আস্তে আস্তে তাকাও ভালো করে, এই দেখো অ্যারাউন্ড গ্র্যানুলেশন, এই দেখো উপরটা গোটাটাই সুপিরিয়র স্যাজিটাল সাইনাস। বুঝলে? একবার ভালো করে আবার দেখে নাও, লেখাটার সাথে মেলাও, আবার দেখাচ্ছি আবার। ইউ উইল গেট দিস many videos, but I thought this will be this is formation in the lateral ventricle, and then it is coming to the third ventricle, then through this part fourth ventricle, from fourth ventricle median aperture subarachnoid space or spinal cord, and from two lasca opening through. Is this part clear? বুঝতে পারছো কিভাবে হচ্ছে? এই ব্রেনটাই দেখতে পাচ্ছ তো, ওখানে যদি এরকম করে না ভালো করে তাকাও, একটু ভালো করে তাকাও এদিকে, ওই ব্রেনটার চারদিকে ফ্লুইড রয়েছে, দেখতে পাচ্ছ ফ্লুইডটা? এমআরআই করলে এরকম পিকচারটা পাওয়া যাবে। এই দেখো ফ্লুইডটা, বুঝছো ফ্লুইড? আমরা এইখানে এলাম। So as I told you, this is about 125 to 150 ml in the adult. You remember this from this much. And just for your understanding, I have divided into three parts. All these parts. What is the actual volume? In the lateral volume, cranial subarachnoid space, there are 100 ml. Out of 125, 100 ml is itself in the cerebral cranial subarachnoid space. The rest is the spinal subarachnoid space, the 25 ml. Now, in the lateral ventricle capacity, you listen, capital ventricle 25 to 30 ml. So it is larger, much larger compared to the third ventricle and fourth ventricle. Size of the third ventricle and fourth ventricle, you see, it is almost same, 2 to 3 ml. So now you can imagine that if there is any tumor which is obstructing that path, the CSF cannot really flow the way it is desired to do so. So this is an approximate idea. So what are the functions of CSF? As I was telling, these 5 functions you must remember. Number one, maintenance of buoyancy. It is basically floating in the cranium. So to ensure blood supply, just at least the points which I have underlined, you remember that thing and tell. And for your understanding, I have made the other points. Protection from injury, most important part. Because without that thing, brain is not protected. It's just like a jewelry box, as I was explaining. When jolted or hit, by providing a fluid buffer, which acts as a shock absorber. Prevention of brain ischemia by decreasing total intracranial pressure, facilitating blood perfusion. This is physiology part. homeostatic regulation and removal of waste product. I was explaining that urinary bladder we are producing, it is getting stored in the urinary bladder we are passing, but there is no such system. So removal of the waste product of the brain is also delivered into the CSF. That is the reason why CSF is required to be also drained, because otherwise waste product from the brain is also having metabolism. So where from it will drain this metabolic waste product through in the CSF itself, and that's why there is continuous formation of CSF and also drainage. So now coming to the biochemistry part, this part was not required if this would have been covered earlier. So composition between the plasma and CSF. Remember, lipid and bilirubin is conspicuously absent in CSF. In the urine you have seen you can get some amount of bilirubin, and that's why the urine color is yellow, slightly yellow, pale yellow, whatever there. It is not just like water. Only if you drink good amount of water, then only water urine becomes very much watery. So CSF, due to total absence of bilirubin, it will be a clear fluid. And you look at the level, the blood glucose level is almost 50% of what the plasma glucose is. From a clinical point of view, glucose and protein is the most important thing, and using these two parameters, you will be able to diagnose the three different types of meningitis: viral, bacterial and tubercular. Why this is important? Because the management of all three are different. Viral meningitis doesn't require that much aggressive treatment because we don't have that much antiviral agents. Bacterial meningitis, the onset is very rapid, just like a viral infection, natural viral infection. Bacterial meningitis is a little bit more severe and it requires antibiotic. So therefore antibiotic selection is there. If it is a tubercular, then anti-tubercular drug is to be given. Now if you cannot diagnose the type of meningitis, you will not be able to treat properly. That is the reason. And these two things can be diagnosed by looking at the glucose and protein level itself, and that's what is my thrust point today class. What is the level? So you can see it is present in the less than 50%, around 50%. So albumin in the blood is present, total protein is present in the blood at 6 to 8 gram %. That means 6,000 to 8,000 milligram per deciliter. I have taken the middle figure 7,000 milligram. 7,000 milligram. In contrast, if you look at this thing, the lumbar region, it is 15 to 45 milligram. So where is 7,000, where is 45 or 40 milligram? So the serum protein and CSF protein ratio is almost 200:1, right down. So it is because of the ultrafiltration, the protein level is less. Similarly, if you look at the globulin level, it is 3.6 gram in the plasma, but in the CSF we are having approximately 0.0115, that is 15 milligram. It's a very low amount. So CSF AG ratio is almost 3:1. So normally serum AG ratio is 1 to 1.5:1. Albumin is much higher concentration than globulin. You look at this thing, CSF AG ratio is 3.1. Why? Because albumin is having a low molecular weight. It is the 67,000, globulin molecular vary. So that's why this predominantly it is albumin. If you look at the other parameters, magnesium concentration is slightly higher as well as chloride concentration. Sodium concentration remain almost same. This is just for your understanding. And pH, look at the pH, it is almost same as blood. Because brain cell also has to be kept in the same pH with the blood. It is not urine, urine is acidic normally. Now for any blood test you will ask that do blood glucose, cholesterol, triglyceride, urea, creatinine, uric acid. You advise. Now who will collect the blood? Who collects the blood? Who will collect the blood? Number one. First and foremost, where from blood is collected? You tell me, where from blood is collected? Forget about CSF for the time being. From vein. From which vein? From the hand. Usually commonplace. From hand, forehand, like this. We don't puncture. In the baby, there is a femoral tap. Because in the baby, we will not get, if you want to do a blood test, because a newborn baby or maybe 3 to 4 months baby, you will not be able to puncture, you will not see, then you have to do a femoral puncture, femoral tap, femoral vein puncturing. Okay, so this is done. See, blood, who draws the blood normally? In the ward? Nursing staff. And in the OPD setup? In the OPD setup? Who? Paramedical staff. So they normally do this job. Now at times they will fail. At times they will fail. The nursing staff will not be able to draw the blood from an adult and also in the OPD setup in the laboratory. Now in that situation, who will draw the blood? Doctor. So therefore your expertise must be much at a higher level than the technicians. So that means you require much more practice than what a technician is. And if you cannot draw a blood, what will be your situation before the patient or patient party? ডাক্তার বলবেন রক্তই টানতে পারেন না, আপনি কি ডাক্তারি করবেন, এই ল্যাঙ্গুয়েজটি বলবেন। Therefore you practice blood drawing. Femoral tap, nursing staff is also not allowed because femoral artery is just lateral to it. If by chance it is punctured, so there will be catastrophic situations. So you have to learn. I had learned from third year itself by going there, approaching many persons, that you adopt policy you have to adopt. So otherwise you cannot have a mastery. And during my also professional life, I used to correct along with the technicians so that I don't lose my expertise. Babies, I used to take them to the pediatric ward and I used to call the nursing staff and used to do a femoral tap. So don't lose any opportunity to lose your expertise. That's my advice to you. Now, where from CSF will be collected? Very fast question. Anybody? Spinal cord. Spinal cord. Spinal cord will be injured if you want to draw, and it is not present in the spinal cord. Nasal. নাক থেকে পাবো কি করে? পাবো নাক থেকে বলো। বলে যে ঠিক আছে নাক থেকে, বলে নাক থেকে কি করে পাবো? CSF কোথায়, নাকে কোথাও বললাম আমি এখানে নাকে কোথাও থাকে CSF? Have I ever told that it is present in the CSF is present in the nose? CSF can be present in the nose. I am telling you. In case of CSF Rhino, oh, extremely disease condition. How CSF? Hey, she has raised a very good clinical question. What is CSF rhinorrhea? No, just explain. Yes, you know, I am quite happy that you are quite aware of this term. I was supposed to tell this thing, but I cannot now resist the temptation. Just explain to your student, to your classmate. Anything coming out from the nose is called rhinorrhea. And when CSF comes out, why? Yes, he is told very correctly. When CSF comes out from the nose, it is called CSF rhinorrhea. Now, usually I had to face this difficulty in my professional life. The ENT specialist used to send a sample, whether it is a CSF or whether it is nasal fluid. Sample sent from ENT ward or OPD. Now, I was the person who has to decide because the management is totally different. If it is a nasal fluid, then you require only that viral antiviral treatment or any antihistaminic drug treatment. But it is CSF rhinorrhea, a dangerous condition. Patient is likely to have meningitis because now it is in continuity with the nasal cavity. Now, where from CSF rhinorrhea will take place? Because if you look at the cranial structure, there is one sphenoid bone and there is a cribriform plate. The roof of the nose is formed by the cribriform plate of that ethmoid bone. That bone, that if there is any leak in that cribriform plate, that is just like a just like a god piece, like if there is any leak, then it will come to the nose. And I think some of your family members might have suffered the CSF rhinorrhea, otherwise she would not have been able to tell this thing. Anyway, good point. So where from CSF is correct? Not from nose. We cannot puncture here. Then normal they will introduce infection. This is directly under the contact with the CSF. We cannot, because CSF is present in the undersurface. It is in pressure also. So if you, what she has told, if you approach to the nose, in nose we are having many infections. So that infection will get introduced. You cannot prevent that thing. So never, it is not done, and every attempt is made so that as soon as possible the closure is made from a clinical point of view. Otherwise, infection will continue to affect meninges and patient is going to suffer from meningitis. Where from CSF is collected? বলো এই তো একজন বলেছে দেখো একটা ওটা ভুলটা ক্লারিফাই করে দিলাম একটু বলো দিস ইজ এসজিডি গ্রুপ দিস ইজ নট এ ওয়ান ওয়ে থিওরিটিক্যাল লেকচার বলো একটা ভুল বললে তবে ঠিকঠাক ঠিক করতে পারবো ঠিক বলতে পারবো কেন ওটা করা যাবে না বলো 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 anyone should volunteer she has volunteered with new information also বলো একটা আইডিয়া করো একটু and second how to collect CSF. It is not that simple just like a blood. So you have to take precaution just like OT operation so that you don't introduce infection into the meninges or into the spinal subarachnoid space. Because if you do not take adequate precaution, just like if you draw the blood, casually we do put a just like a sterile needle because it is not that important. But if you by chance introduce infection from the skin into the meninges, patient will suffer from meningitis. This is called iatrogenic meningitis. Means you are introducing the infection. Patient did not have that infection. So you have to take all the precautions just like abdominal operations. The way the abdominal wall is sterilized before putting an incision, the same thing has to be done. Using all acceptable methods. Who will collect CSF? Yes. No other option. A medical graduate, at least. So this cannot be given to the nursing staff. So you have to practice, practice and practice. There is no way out. You observe very carefully how it is being tapped, and then at the earliest opportunity to grab the opportunity under supervision you try to puncture. The more you puncture, the more you will learn. And when there is an outbreak, simply volunteer yourself to that ward, hospital. Each and every patient CSF will be required to be collected. So all the doctors are becoming really tired. So in that condition, you get a golden opportunity to learn CSF. Simply volunteer. In Bardhaman Medical College, there is a ventricular ward during every year in the month of October. It was loaded with patients, and I got the golden opportunity to learn CSF puncture. This lumbar puncture. Basically, it is punctured from the lumbar region. L3, L4 vertebra. Why? You are note down from L3, L4 vertebra, interspinal space of the L3, L4 vertebra. See, look down. Why it is from L3, L4? I am telling you. The spinal cord, you have seen, it is ending at the lower border of the L1. So it is basically between L1 and L2 space. Now, if you put a needle here, you are likely to injure the terminal part of the spinal cord. There is a possibility. So therefore, this space is not preferred. L1, L2, no. L2, L3, sometimes it might extend also. So L3 and L4 is the actual site from where it is interspinal space, from where it is actually produced. So how it is done? Normally, we remain like this, spine is like this. So the spinous process, this is the structure, suppose. This is the structure, spinal canal. And the patient, if you lie down in this position, horizontally, on one side of the bed, the spinous process will remain like this. You can feel it on the back, the bony projection. Now, if you remain it like this, so it will be having a narrow space. We are bending, forward bending, because ligament is there. What it is doing? It is simply stretching this thing. So this space is getting a little bit widened. So they allow the person to sit down, lie down on the one side of the bed, and then you how to determine the L3 and L4 vertebra? How you determine where is the space? One point you can count from the tip of the, you come here, you just bend your head. The highest point here is C7. From C7 you can have to count down. It is very difficult. For obese person you cannot count it properly. It is not possible really, honestly speaking. Only thin body it is possible, but all the vertebrae may not be thin. And by mistake, if you cannot do this thing, then you are basically will be lost. Why? This part is important. So how will you identify L3, L4 vertebra? Just tell me anything from your anatomical knowledge. I think this has been told during your anatomy class. Applied aspect of anatomy aspect. Now you just, all of you have tried to fill on the top part, here this part. Just fill it, fill this part, fill on the top, you will see a body margin. This is the highest point of the iliac crest. And if you go a little bit down, you will see the anterior superior iliac spine. If you go backwards, you will see posterior superior iliac spine. So highest point of the iliac crest, if it is there, and if you make a perpendicular line like this, exactly perpendicular line, be very careful. Their space will correspond to this space, L3, L4, exactly L3, L4. So highest point of the iliac crest you have to identify, you have to make a perpendicular line, and then you have to identify this part and ask the patient to bend, curve, make a curve as much as possible to increase this space. To increase this space. This is the basic purpose. As much as possible. Now, after doing this thing, you see the aseptic precaution, means this OT precaution. Where a lumbar puncture needle is something like this, like a spoke. There is a skin. You see, this is the opening you can see. This is the opening. This will be covered with ligaments. It will not be that opening. So you have to put a needle like this, very carefully here, and you have to draw it, put it there. So first, the moment you put the needle inside the skin, there you get find a resistance. The resistance will remain. Suddenly it will go into the intervertebral, this ligament space. Again there will be resistance. It will suddenly give way. That means it is piercing the dura mater and it is in the subarachnoid space. Now in the fluid, and the fluid will start coming from the other side of it. So if you cannot really do this thing properly, you will hit either here, and fluid will never come, and you cannot do a repeated attempt is not permissible. This is a very painful procedure. First and foremost, we anesthetize the upper part, so there will not be any pain. But as you go inside, the entire thing is not anesthetized. So there will be it's a painful procedure. So you have to be very careful. At the first time if you fail, again you have to take a separate lumbar puncture needle, and again you can have to do it. At the best you can do twice, not more than that. Now if you cannot do, can you imagine what is the condition? Patient's pain will be there, and there will be edema also because you have punctured. So anybody will not be able to correct this thing. And the moment you cannot diagnose, you cannot draw the CSF, it can only be analyzed. That means diagnosis will remain suspended. So this part you have to learn. Do you understand? You have to put the needle inside, and you have to not go to the directly and hit the other part. Because then you are hitting the other side and fluid will not come, and the needle has gone into the other side of the bone. That means it is touching the other side of the subarachnoid matter, subarachnoid matter. So needle is touching like this, fluid will not come. So in that case, you have to move a little bit. Because spinal cord is not there, you see the needle is here. If you push a little bit more needle, it will hit there. You just adjust the needle little bit. The other side of the needle is open. From the other side, the fluid will start coming, and you collect in a container. Okay. So that I have taken a little trouble to explain this thing. because you have to do it. And best thing is to observe 2 to 3 times by an expert who is doing, and then you, under his guidance, you do this procedure. So CSF, remember, is a very infectious material. You have to protect yourself. So handle it as an infectious material, because it will have virus or bacteria or TB. So you must not get infected. Second, since 100 out of 125 ml, at least 6 ml of CSF will be taken out from the spinal cord, there will be a sudden decrease of volume, and that will cause lumbar puncture headache, post lumbar puncture headache. Because of this thing, the patient is not asked to move from the bed after lumbar puncture for 6 to 8 hours. By that time, because of the continuous flow, there will be readjustment, so patient will not suffer from that thing. So if you, before lumbar puncture, ask the patient to go to the toilet also, so that he will not be required to pass urine also. That much precautions you take it. I hope you will be able to do that thing. So this is basically important. Meningitis, commonest is 3 types: viral, bacterial, and tubercular. It can cause encephalitis. Encephalitis means inflammation of the brain. Encephalon means brain. So since the meninges is in continuity with the cerebrum, encephalon, that means some amount of encephalitis might be also there. Similarly, if there is a predominant encephalitis, there is some amount of meningitis also. It depends on how severe is the disease. So there will be ideally only meningitis, only encephalitis, or meningoencephalitis. Subarachnoid hemorrhage is also an indication. Brain tumors, other serious. Today we are having, at least the last 2 decades, we are having CT scan MRI. With the advent of CT scan MRI, subarachnoid hemorrhage, brain tumors, these can be diagnosed. Demyelinating disease also can be diagnosed, but GB syndrome requires, the Guillain-Barré syndrome requires CSF. You will not get a confirmation without CSF examination. So this case is rare. I have seen only 1 case during my internship. It is still during my student life, not during my internship. So if you get an opportunity to see these type of rare cases, don't lose any opportunity to examine whatsoever important job you have. So these type of patients will not get so commonly. So what the question will be why I have written this thing? Because a question will be asked: a patient has come to the medical OPD with a history of fever, because ITC is there, means fever will be there. There will be some fever. Viral infection, as you all know, that there is some amount of fever. Bacterial infection also, we suffer from fever. So fever is a common thing. In addition, there will be headache, because now meninges is inflamed. So it will cause headache. There will be neck pain, and neck will not be, the patient will not be able to move the neck also. So neck rigidity will be there, and alteration of sensorium, because normally we are having normal response. This type of response, patient will feel a little bit drowsy or unconscious, even semi-conscious. So what the question will be, in the first question, the patient has come with a history of fever, neck pain, neck rigidity, and some sort of unconsciousness or semi-consciousness. CSF examination revealed following things. What is your diagnosis? So that is the reason why I have written this part. So this is just for the first sentence of the question. So it will give an indicate the moment you see the neck pain, alteration of sensorium, think of some CNS involvement. Alteration of sensorium doesn't occur normally in other conditions until the disease is very severe. But here it is primarily affected. So therefore there will be alteration of sensorium, drowsiness, consciousness, or any neurological problem. So again come to that particular point where I have said the CSF in the subarachnoid space, CSF comes in contact with the perivascular space, thrust area where the blood vessels is entering and leaving, where from cells and protein leak. And this is the crucial, most crucial part. And I repeatedly told, if there is obstruction of the CSF flow due to tumor or other neurological disease. I have also told that albumin is a predominant protein. Globulin can also be high if there is any immunological disease. Those who have attended my immunology class will understand in what conditions the globulin levels, immunoglobulin levels will be increased because of the immune response. Some autoimmune diseases are also there in the brain and spinal cord. If there is a marked increase in permeability, fibrinogen is a very high molecular weight protein, fibrinogen will come. It's a 340 kilodalton protein. In contrast, albumin is having 67,000, 67 kD. So when there is a remarkable increase of permeability, usually in tubercular meningitis, it happens in tubercular meningitis, fibrinogen is present and fibrin clot is there. So it is usually 2 ml are collected in 3 tubes because the central lab in one container you can collect 6 ml, 5 to 6 ml of blood and send it directly to the central lab. Otherwise, if there is in 3 different places it is done, so you need to do in 2 ml in each tube. So biochemical test is done only for glucose and protein, no other parameter. Cytological, cell count and cell type. And bacteriological, whether the bacteria are present or what causative agent is present. If it is a bacterial meningitis, then you will get bacteria. If it is tubercular, also you will get tubercular. If any other causative agent is there, that causative agent can be found. And usually a sensitivity is also done with what antibiotic will be the best antibiotic for that particular individual. That can be also diagnosed empirically on getting a primary diagnosis to start the treatment. And then by 48 hours you will get the report and you start the specific treatment also. So just by looking at the CSF, you can diagnose. Looking at the biochemical part, you can diagnose. Looking at only pathological part, you can do cytological. If you combine both the things, diagnosis will be very easy. So glucose examination is done always on a priority. If you do a CSF analysis, you inform the central lab head that a CSF sample is being sent, and it is done on an emergency basis. Other routine parameters are kept in suspended temporarily, and that CSF is analyzed, immediately report is communicated because this is a serious condition. So therefore, you always try to have a communication with the laboratory. So it is a priority sample. Sample needs to be centrifuged fast. Glucose estimation is done normally by the GOD method, what you have done. It is true for all body fluids. Protein estimation, you have done sulfuric acid, same thing is done. Only thing is that we have to quantify what is the amount. And there is another method, that is pyroglycal method, that this is just a standard curve, conventional standard curve, just like blood glucose, what I have told you. So the upper limit, this I have practiced during, and this is still in vogue. This is a very stable method, and the upper limit here is up to 100. Now, if the value is more than 100, we need to dilute the sample and multiply by the factor. Like if you dilute it doubly, 1 in 2, then you multiply by 2, whatever figure. If I diluted 1 in 5, then multiply the figure by 5. This is just like another method. Write down this one, special test. Those will be answering good question. What is the test for globulin? A Pandey's test. It is a test for globulin. What is done? A phenol reagent is added. 2 drops of CSF is given, and the degree of opalescence is measured. Since globulin level is higher in only in diseases which are caused by immune-mediated injury to the nervous system, one example is multiple sclerosis. Again, this is a rare disease. This can be diagnosed by MRI, but if you have any doubt, you can do also CSF, and you do ask, especially ask for Pandey's test. It is normally not done. It is a very special test for CSF. A normal appearance of CSF. It is a clear, remember, it is just like normal water. Clear, transparent and colorless. Protein level is only 15 to 45 milligram. Cell count is usually less than 5 and is predominantly lymphocyte. Write down this. Appearance in diseases. It can be clear, it can be slightly turbid. What I suggest to all of you, since you will not get a CSF sample so easily, whenever you will suffer from any rhinitis, common cold, you try to collect the nasal fluid of yourself on the first day itself in a test tube and look at the appearance. that appearance will be just like viral, because it is a viral infection. You will get a color slightly turbid or clouding simply. Now, as you increase, all of you have seen that the nasal secretion also thickens. So, second day you collect the sample, you see that turbidity more also. Keep it in the fridge so that you have a look. Whitish and turbid, if you get, this is basically bacterial. And if you get slightly turbid, this tubercular. So, by appearing while you are collecting the blood, CSF, you will be able to provisionally diagnose what type of CSF it is. If it is a turbid one, there is no need to ask anybody what type of meningitis it is. So, it can be a frank pass also. If the infection is very severe, you will diagnose that is a bacterial meningitis. A slightly turbid is a tubercular. Redness, if it is there, it can be hemorrhage. What happens while you are inserting the needle, any capillary can come on the way, and that capillary can be punctured. Blood will come into that CSF function, lumbar puncture needle. So that can give, or otherwise, if there is a hemorrhage also in the subarachnoid space, you will get a frank hemorrhage also. And xanthochromia means uvulous discoloration. The spinal, it is uvulous discoloration, that is called xanthochromia. I have diagnosed one case of subarachnoid hemorrhage, and I found xanthochromia. Because these are the cases you will not get that golden opportunity to see. So blood in CSF, it can be arthritic accidental pricking during lumbar puncture. It's a hemorrhagic tap basically. Now, how to rule out? So, if you have made a puncture, accidental puncture is there, blood vessel is there, initial samples will be bloody. Now, next samples you can see that it is clear, more clear. So, you have to collect this thing. So, what happens during this time, 6 ml of blood you have, CSF you have wasted. So, you need to collect some more. So, patient is likely to have much more post-lumbar puncture headaches. In that case, much more period rest is required also. Because you don't know where the blood vessel might be just like in front of the needle in the meninges itself. So, the hemorrhage can be cerebral, it can be subarachnoid, it can be anywhere in the serous system. So, if it is a frank blood, then the whole of blood will be there. If you allow it to settle, it will settle like this. Now, if it is due to subarachnoid hemorrhage, the color as you can see, it is not normal, it is slightly yellowish. And the yellow color is due to bilirubin. Okay. So, basically in xanthochromia found only in subarachnoid hemorrhage. So, there is RBC lysis in the CSF, and from our heme is released and the bilirubin production. The same thing. So, at least 12 hours time is required. If the patient presents, don't go for immediate lumbar puncture. So, we have to wait for 12 hours. This is normal, this is abnormal. If there is a degree of hemorrhage is very high, then of course, it will be just like a serum color, high colored bilirubin. So that is called xanthochromia. So Fryns syndrome you will be taught in the clinical class. So it's a triad basically. You need to remember at this stage. 1 point write down. Albuminous cytological dissociation. This is diagnostic of Guillain-Barré syndrome. What happens during inflammation? There is a proportional rise of cells and protein because of the leak. So there is association between the rise of the cell count and the quantity of the protein. But in this condition, there will be dissociation. That is the reason why it is called albuminous cytological dissociation. So elevated CSF protein level in the relative absence of CSF leukocytosis. The cell count will be lower, but protein level will be, compared to that thing, it will be higher. So it is a hallmark of Guillain-Barré syndrome. So in the acute phase, characteristic in the acute phase, what happens? There is elevation of CSF protein. But at that time, CSF white blood cell is not increased. Isolated elevation. In the early phase. So viral meningitis, as you can see, the appearance is slightly turbid. So findings in viral meningitis, color will be, remember, clear, colorless, maybe slightly turbid. Protein, normal or slightly increased. Usually it is more than 45. 45 is the normal level, upper limit. It will not be normal. পরে ফোন করছি তোমাকে, আমি কল ব্যাক করছি পরে। এই রেজিনাকে আবার ডাকো তো, এই স্যাম্পলগুলো নিয়ে যাবে এগুলো, তোকে ফোন করতে বলো, রেজিনাকে বলো যে অ্যানাটমিতে ফোন করতে বলে এটা নিয়ে যাওয়ার জন্য। আচ্ছা দেখো, ভালো করে দেখো, গ্লুকোজ লেভেল উইল বি নর্মাল ইন CSF। একটু ওকে স্পেস দাও, একটু স্পেস দাও, একটু শুনে না ভালো করে খেতে। সেল কাউন্ট ভালো করে দেখো, প্রোটিন লেভেল উইল বি স্লাইটলি হায়ার, ইট উইল নট বি নর্মাল। Glucose level may be normal because virus cannot consume that much of amount of glucose. The cell count is usually typically lower, usually 22 to 500 ml, and mostly it is lymphocyte. Any viral infection anywhere in the body, remember, lymphocyte count will be high, total count will be high, total WBC count will be high, but if it is a lymphocyte increase, that means the infection is of viral type. If it is of polymorphonuclear nucleoside and neutrophil, it is of bacterial type. Anywhere in the body, in the blood also, same thing is true here. Now bacterial meningitis, you can see it is basically, you can, if you have suffer from anytime any pus anywhere in the body, collect it in water, you just add a little bit salt to it so that it becomes saline, and give that pus into that water, you will get a color like this. So while you are puncturing CSF, you will be able to diagnose whether it is a bacterial meningitis or not. And if it is very severe, you can see a frank pus. And I have seen in my brother-in-law also at PLS hospital, this it was punctured. I was present during that. Even in CT scan, it could not be diagnosed. Then the surgeon was there. I told him, let us do an LP. What is the problem? Let us see what is the patient was unconscious. He was brought from Chandanagar Sub-Divisional Hospital to District Hospital to PLS Hospital. I was accompanying him. Severe alteration of sensorium, some kind of non-rigidity, and we ruled it out by CSF only. So bacterial meningitis, what will be the finding? It will be opalescent and turbid, never normal. Never normal. Protein count will always be higher. Glucose count will be remarkably decreased because the bacteria will consume glucose for its own survival. So in that small amount of glucose whichever is present in the CSF, the bacteria will start consuming. And if the amount is very high, it can reduce the level to 0. And in fact, I have got 2 cases in my life, 0 CSF glucose level in CSF. And unfortunately, unfortunately, no laboratory gives 0 result. Ideally, they give 5, 10 like this. If you see a clear turbid fluid during cell type, go to the lab. Ask the lab person, show me the result on the oral result. He will try to hesitate. And you take a distilled water along with you also. Ask them to measure glucose level. If it gives 0 result, then the machine is calibrated properly. If it is not, if it gives 5 result, that means there is no proper calibration. So it can be 0. Only trigger point, only thing is that CSF glucose ratio will be less than 0.4. Whenever you are drawing any CSF analysis, you draw a blood glucose sample also. Suppose the patient is diabetic, he is having a blood glucose level of 400 or 350. Do you think the blood serum level will be, the glucose level will be the same, but in a normal individual? No, his CSF glucose level will also be high. So that is important. So simultaneous drawing of blood is also important. And now if the CSF serum glucose ratio is less than 4 or plasma glucose ratio is less than 4, you diagnose this case. Cell count remarkably increased. And cell type, as I told you, it will be predominantly neutrophil. May clot outstanding may be there. So normally less than 0.4 is basically suggestive of bacterial meningitis. Tubercular meningitis, coagulation is the characteristic feature, but it takes about 12 hours time overnight, so you have to keep the sample overnight. And then only you will be on the morning. In our time, there is no advancement of so much advance of science, so we have to keep this thing and we have to see on the next morning itself, next day also. And you will see that this clot, I have like this. If this type of clots are there, and this is a microbacterial, so bacteria may be trapped in the strap. So from that, bacterial staining can be done also very well. So tubercular meningitis, it can be clear or opalescent. It may be cloudy. Protein content is remarkably increased. Glucose content is low, but not that much low with bacterial meningitis. Cell count, it will be usually less than 100, less than 500. Cell type, since this is an immune-mediated injury, disease, so the count will be lymphocyte. And coagulation will be there if it is more than 12 hours. I think you are now restless. This is a comparison point, what I have told. Now, one of you have to now say what is the diagnosis. Because as I told you, a history will be given, and then this picture, CSF results show this finding. What is your diagnosis? Other questions will be how CSF is formed, how the material is formed, this type. Now you tell me the diagnosis. You said bacterial. See, he said bacterial. How many of you support him? You support him. You support him. You support him. Just look at this picture. He said bacterial. And he supported also. She supported also. Bacterial. Again, another point of person. Now you supported just to support. Many persons are quiet. A person is intelligent so long he keeps quiet. A person, or stupid person should I say, is intelligent so long he keeps quiet. So you will not understand whether he doesn't know or he doesn't know. They have opened their mouths. So they will learn better than those who are keeping quiet. বলো 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 শুনতে চাইছি ও বলেছে দেখো সাপোর্ট করলে চারজন anything else it could be normal. Can it be normal? Can it be tubercular? Bacterial tuberculosis, I told you specifically tuberculosis is also bacterial, but a special type of bacteria is there, so it is not absolutely synonymous with bacterial meningitis. So we have deliberately told viral, bacterial and tubercular meningitis, specific type. দেখো এবার দেখো একটা হিন্ট দিচ্ছি এবারে একটা হিন্ট দিচ্ছি হ্যাঁ কিচন জিনিসগুলো এবার নিয়ে যাচ্ছি করে গেছি আজকে হলো সেদিন তো 26 তারিখ এগুলো তো আছে না এই তিন এই দেখো চারটে 24 3 24 দেখো না এই দেখো হ্যাঁ লাম্বার ঘাটি পড়ে এই দেখো দেখো ব্রেন উইথ স্পাইনাল কর্ড cellular section of the brain, cranium, আর পাঁচটা লাম্বার ঘাটি বলো 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 কি এইবারে জাস্টিফাই করে এটাকে অফ করছি এটাকে নর্মালি করা হয় না আজকালকার দিনে এটা করা হয় না এবারে এইটাকে জাস্টিফাই করো দেখি এটাকে জাস্টিফাই করো দেখলে ভুলটা এবার বুঝা গেল এবারে জাস্টিফাই করো দেখো চিন্তাটা একটু পাল্টাও যারা যারা হ্যাঁ করেছিল ব্যাকটেরিয়াল বলেছিল তারা এইবার একটা চিন্তাটা পাল্টাও দেখো এটার মধ্যে আনসারটা পাবে একটু চিন্তা করো দেখো হ্যাঁ ঠিক আছে একটু চিন্তা করো আজকে দেখো একা পারবে না আপনারা নিয়ে যেতে সাবধানে নিয়ে যাও সাবধানে নিয়ে যাও দেখো এটা করা যায় দেখো প্রথমে দেখো কালারের দিকে ক্লাউডি ওকে এইটাই মোটামুটি একটা সিগন্যাল দেবে ইট ইজ ভাইরাল অর টিউবারকুলার দুটোর মধ্যে একটা কিছু এটা নর্মাল ধরে নয় তাহলে এইবারে এই পার্টটা বাদ দিয়ে দাও প্রোটিন আর গ্লুকোজের দিকে তাকাও ইউ সি দ্য প্রোটিন গ্লুকোজ লেভেলটা খুব বেশি কমেনি প্রোটিনটা কি রিমার্কেবলি ইনক্রিজ করেছে দেখেছো এবার এইটা অফ করলাম এটার দিকে তাকাও সেল টাইপ এন্ড সেল কাউন্ট 550 হয়েছে predominant lymphocyte. Two conditions will increase, one is viral, one is tubercular, okay? Both lymphocytes will be increased. But in viral meningitis, it will not be, that cell count will not be that high and protein will not be this much increased. So significant increase will not be there. So it is not viral. Okay? Remarkable increase is there. So this is one clicking point. What is this? বলো বলো এটা চেষ্টা করো বলো এটা তো বললে প্রথমবার দেখো ভুলটা বেরিয়ে গেল বলো বলো বলার চেষ্টা করো কে কে তুলছে এই তো বলছে মুখ খুলছে দেখছে মুখ যতক্ষণ না খুলবে ততক্ষণ শিখতে পারবে না মুখ খোলো তবে তো শিখিয়ে দেবে দেখো নিজেরাই বলতে পারবে ওটা একজন বলে যে কত সুন্দর জোরে বললো এমফ্যাটিক্যালি বললো ভাইরাল বাকিরা তো চুপ করে রইলে মানে আমি এতক্ষণ ধরে ফেলিওর হয়ে গেলাম এটা দেবে পরীক্ষা এরকম জিনিস দেবে একদম এইটাই দেবে তার নাই কোনো মানে নেই বাট এরকম কাছাকাছি করে একটা ফিগার দিয়ে দেবে বাট এগুলো রিয়েল পিকচার ফ্রম মাই প্রফেশনাল লাইফ আই হ্যাভ টেকেন ডিউরিং মাই career. I have collected some of these things and I am showing it to you. বলো 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 এই তো ঠিক বলেছো তুমি কিন্তু ঠিক বলেছো she has told very correctly না তুমি জাস্টিফাই করো এখানে এসে তো এখানে এসে 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 আই উইল বি হ্যাপি আই উইল বি ভেরি মাচ হ্যাপি তুমি খাতাটা রাখো এখানে এক্সপ্লেন করো দেখে করো কারণ খাতাটা রাখো না যাও প্লে মাই রোল অ্যাজ এ টিচার এই খাতাটা রাখো এখানে খাতাটা রাখো পেনটা রাখো জাস্ট মাস্টারলি ইউ টিচ রেঞ্জ আছে কি রেঞ্জ আছে খুব বেশি বাড়েনি তুমি ভালো করে যে মেন পয়েন্টটা সেটাই তুমি বললে না প্রোটিনটা দেখা তাকে স্লাইডলি ইনক্রিজ করেছে প্রোটিনটা বেশি ইনক্রিজ করা যাবে ঠিক আছে ক্লিয়ার থাকলে এরকমই পাবে স্লাইডলি যদি একটু প্রোটিনটা বাড়তো এটা যদি মনে করে 100-র কাছাকাছি আসতো তখন এইটা ক্লিয়ার থাকতো না এটা ক্লাউডি হয়ে যেত এই সেল কাউন্টটা তখন আরো একটু বেড়ে যেত সেটার জন্য ওই যে ক্লিয়ার অ্যাপিয়ারেন্সটা সেটা কিন্তু নষ্ট হয়ে যেত বসো ঠিকঠাক বলেছে এই দেখো নব করবে এটা ইফ ইউ লুক এট দিস পার্ট biochemistry part only forget about this part look at this biochemistry part glucose level is remarkably low protein is much higher but not as high as that particular. Now look at this thing, cell count so high and the neutrophil count is again 90%. As I told you in bacterial and infection always lymphocyte neutrophils will be increased in viral and tubercular lymphocytes. Make it a rule. Now what is this? Viral. দেখো এবার বলো এবার যে বলো নেই সেগুলো মুখ খোলো যে বলো নেই মুখ খোলো তুমি বলার চেষ্টা করো তুমি পারবে ভাইরাল ঠিক ভাইরাল এই তুমি মুখ খোলো এই যে তুমি মুখ খোলো তাকাও এদিকে ওদিকে তাকাতে হবে না ওইদিকে তাকাও ওটা দাঁড়াও ভুল বলো তুমি কিছু যা বলো ও বলে যেতে ভাইরাল তুমি দাঁড়াও ভাইরাল কে বললে ওদিক থেকে কে বললে ভাইরাল দাঁড়াও এই তুমি বলো দেখো একটা কথা খুব বলা করে বলেছিলাম ক্লিয়ারলি the most bright students even usually on the back benches it is not my statement the statement of APJ Abdul Kalam and she was sitting quietly on the corner and answered very correctly this is a normal report বসো তাকাও সেল কাউন্ট কোথায় আছে 5 তাকাও কোনটা তুমি abnormality পেলে কোথায় abnormality পেলে তুমি খুঁজে এইবারে কি হবে জানো তো you will face some kind of situation like this you have punctured and CSF report is normal maybe you have punctured 3 to 4 times and at the end you get a normal report. Now what will be the reaction to the party to onto you? এই দেখো দেখিয়েছে মা হ্যাঁ এই বাঁচানোর রাস্তাটা বলে দিচ্ছে এখনই ও একদম পরিষ্কার বলে দিল মারবে 4-5 বার যদি ক্লিক করে যদি ফাইনালি এই রিপোর্টটা পাওয়া যায়, what is the expected guess, particularly if it is a baby? And today 1 or 2 babies, there are species, particularly male child, first child. আপনি আমার ছেলেটাকে 5 বার ফুটিয়ে নষ্ট করেন রিপোর্ট, এই ল্যাঙ্গুয়েজ তোমাকে প্রথম রিয়াকশন সহ্য করতে হবে। So how you manage this crisis? There I am teaching you. So during your clinical investigations, most of the reports you will find normal. So before the patient reacts, you adapt a policy. এই ব্লাড টেস্টগুলো করে নিন, নর্মাল পেয়ে গেলে খুব ভালো কথা, না পেলে তখন তো চিকিৎসা করবো না। আপনার যদি কিছু abnormality বেরোয় তখন তার চিকিৎসা করা যাবে। আমার আশা করা যায় রিপোর্ট নর্মাল হলে পেলেও পেয়ে যেতে পারে, ব্যাস ওই মুখে বন্ধ করে দিলে ওখানে। দ্বিতীয়বার তোমার এইবারে এইখানে যখন হবে প্রথমে যা পেশেন্ট বলছে চুপচাপ শুনবে, রিয়াক্ট করবে না কিছু, বলবে দেখুন আপনি নর্মালি ওর তো কী নিয়ে ভর্তি হয়েছিল, ওর একটা ফিভার ছিল, ওর মাথা ব্যথা ছিল, ওর নেক পেন ছিল, আপনারা নিজেরা এসে বারবার আমাদের বলেছেন, তার জন্য আমি এলপি করেছি। নর্মালি এলপি করিনি, আমরা কষ্ট দিতে চাইনি। থ্যাংক গড ইটস এ নর্মাল রিপোর্ট। আপনার বাচ্চাটা আর কিছু হয়নি, আপনার বাচ্চাটা হয়নি, আমি খুব খুশি। অ্যাটলিস্ট আপনারা খুশি হন। ব্রেনে যদি ইনফেকশন হয়ে যেত, মেনিঞ্জাইটিস হতো, এর যে ভবিষ্যৎ কী হতো আমরা কেউ কিছু জানি না। অ্যাটলিস্ট হ্যাঁ কষ্ট আমি দিয়েছি, আমি মানছি, আর চুপ করে যাবে, চুপ করে সঙ্গে সঙ্গে কোয়াইট হয়ে যাবে। এটা যদি অ্যাবনর্মাল রিপোর্ট হতো, ভাবতে পারছেন কি কতগুলো ইঞ্জেকশন দিতে হতো বাচ্চাটাকে। আর আমরা জানতাম না যে তার কি প্রবলেম হয়েছে ব্রেনে। এইটুকু বাচ্চা ভাই মেনিঞ্জাইটিস বলে কথা, এত বড় ডিজিজ নিয়ে তুমি যা পারো গ্লোরিফাই করো মেনিঞ্জাইটিসটাকে যেভাবে পারো। ড্যামেজ, দিস ইজ কল্ড ড্যামেজ কন্ট্রোল এক্সারসাইজ। যদি কিছু ড্যামেজ করে ফেলে পেশেন্ট মরে যাবে, ভাবো স্পট ছাড়বে না কিছুদিন, 8 ঘন্টা 15 মিনিট অন্তর আসবে, সে পেশেন্টটাকে দেখবে, ব্লাড প্রেশার দেবে, পাস দেবে, অক্সিজেনটা দেখবে চলছে কিনা। পেশেন্ট খুব চিৎকার করাকে তোমাকে ভাববে না ডাক্তার কেয়ারের কোনো অভাব হয়নি। সো ড্যামেজ কন্ট্রোল এক্সারসাইজ ইজ অলসো রিকোয়ার্ড ইফ ইউ অ্যান্টিসিপেট সামথিং। সো before you react, try to get the report from the laboratory. কি রিপোর্টটা কি আছে? So you get prepared yourself. Okay. So this is called meningism. It is not meningitis, but meningitis-like feature. But this is called meningism, and because of the meningism feature, you have done an LP.